This program is brought to you by Emory University.
Good morning, everyone. We're going to go ahead and get started. This morning we have Brad Leshnower with us. Many of you know Brad, or perhaps all of you know Brad, who is a member of the CT surgery group here. Brad did his medical school at UT Southwestern, did his cardiothoracic surgery training here, and a little bit of training Penn and Arizona, yes. Along the way. And as all of you know, his major interest is really in diseases of the thoracic aorta, aortic dissections and aneurysms, and is very interested in both the mechanisms and the management of those individuals. So today he's going to talk to us about that organ we sometimes forget about in cardiology, the brain, and cerebral protection in aortic arch surgery. Brad, welcome.
Thanks, Bob. We're going to try and go nuts and bolts over the history and various methods that we use to protect the brain when we're involving the aortic arch. Some of this may be rudimentary, maybe not. I just want to, my goal is for everyone to have a really good understanding of why we do what we do. So outline, we're going to talk about where it all started, the deep hypothermic circulatory arrest, then adding in adjunctive brain perfusion, either retrograde, antegrade, the pluses and minuses of all three methods, the evolution to what we do here, and we've been very impactful, certainly in this country and maybe internationally with the work that Ed Chen and I have done on moderate hypothermic circulatory arrest. We'll show you some data from Emory, from our group here, and then a couple of clinical trials, including our own. So I wanted to start off, like I said, basic, and if I'm insulting anyone's intelligence, I apologize. But the basic setup for any true cardiac surgery is, to keep it simple, you have a venous cannula in the right atrium that goes into the IVC. That draws blood out of the heart, goes to the pump, gets oxygenated, and is put back in a cannula that sits really in the distal ascending aorta or arch. And so when we work on the coronary arteries or intracardiac structures, valves, et cetera, we put a clamp on, we put cardioplegia into the aorta, and then we work. But the whole time the brain is perfused on any true cardiac operation. So that's a key thing to understand. It's always getting blood. But that can't happen when you're working on the arch, okay? Because obviously we have to take all this tissue out, either half of it or all of it. So by definition, to get a good, clean repair, you have to suspend blood flow to the brain or do some sort of different type of cannulation to get blood to the brain, which we'll talk about. And one key thing for you guys to understand is really the modern aortic surgeon, if you have an ascending aneurysm, not even an arch, but an ascending aneurysm, people who do aortic surgery, that is, they at minimum get a hemiarch, which is cutting the aorta, and I'll show you some pictures of that, but here, so that you eliminate all disease from the ascending aorta. So no longer, it is extremely rare. If they have an isolated root aneurysm, it's different, but if they have aneurysmal disease going up into the ascending aorta, we don't put a clamp right here and just cut it off and sew to the clamp. That is a very old school way of doing, but it leaves disease behind. And now that we've, what I'm going to show you with evolved with techniques to protect the brain, it is much safer to take all the aortic tissue out. Same thing with dissections. Very key point. So how can we do this? How can we replace the part or all the arch and suspend blood flow to the brain and have a neurologically intact patient? So the first thing is to get a bloodless field, all right? And to do that, we use circulatory arrest, which when I first, during medical school, heard this term, I was just blown away that you could stop the blood to someone's brain and for a while and body and then have them wake up. We have to think about organ protection, the brain, but also the visceral organs and of course the heart. And surgical technique, which we will not really focus on in this talk. So a couple of key points to really wrap your hands around and why we freak out about and why we're having this talk. So the metabolic rate of the brain and energy requirements are 7.5 times the metabolism of any non-nervous system tissue. About 15% of the cardiac output under resting conditions goes to the brain. So your blood flow to metabolic rate is about 20-to-1 ratio. So really, and we all know this, the brain is intolerant of ischemia. You have about 2 minutes of glucose in your cells before you convert to anaerobic metabolism. And when that happens, then you start developing intracellular calcium and the cells die. So you have sort of 2 minutes really at normal thermic temperature before you start having brain death. So a couple of metrics that we think about. In arch surgery, neurologic injury is due to two things: either atheroembolic disease, which most of these aneurysms are atherosclerotic, so it's a big deal, and those result in a focal deficit, a weakness in an arm, et cetera. We consider that to be a stroke or a permanent neurologic deficit in the nomenclature in our literature. And then you have the global cerebral ischemia, which is the brain protection, which we're going to focus on. These patients, if they have long circulatory rest times, they'll wake up either with seizures, non-focal deficits, delirious, confusion, obtunded. They may wake up and they're moving everything, but they're on, Mars, okay? And you guys have seen, quote, pump head. It's probably similar to that, although pump head is considered something we see where they're confused, but they've had blood flow to their brain. But if you don't protect the brain in arch surgery, these people can never be the same, or they will have neurocognitive deficits for the rest of their life. There's a term that is used, and I think it's going to go out of style, but in the literature currently, transient or temporary neurologic deficit in our literature refers to somebody who wakes up like that. You scan them, and their brain imaging is normal, but they have no focal neurologic deficit, but they are clearly out of it, delirious, et cetera. The neurologist would still refer to that as hypoactive delirium, and they may be right. So hypothermia is a key component of our protection of the heart during heart surgery, but really the brain is key. So how does it work? Well, it reduces cellular metabolism, and that's the basic one-liner that you need to understand. John Lewis conducted the first ASD repair successfully without, this is pre-cardiopulmonary bypass, by venous inflow occlusion. He probably put ice packs around the body till he got the patient to 28, and then opened it up and repaired an ASD, and it was successful. That was pre-bypass. He also used it to treat somebody with an ovarian cancer problem, and he basically cooled the body really low and debulked all this disease from the abdomen, and it also worked there, bloodless field. Hypothermia has now been combined with circulatory arrest to result in deep hypothermic circulatory arrest. Now, Randy Greep is a surgeon from Mount Sinai who is really just sort of the father, really, of circulatory arrest. He did a lot of basic science animal experiments and combined it in a translational form and took it to the bedside, and is really the father of this stuff. His aortic symposium in our field is the prestigious one. And he was the first guy to have a series of four patients in 1975, he reported on it, successful arch replacements. What he would do is he would put the patient on bypass, cool him down to 18 degrees, and shut off the pump. And then he would take off an island of the great vessels, sew to the distal descending, sew that to the proximal, reimplant that, and warm them up. And he was successful. It worked. And this really ushered in the era of being able to do arch surgery. And deep hypothermic circulatory arrest was used as a primary modality of brain protection for the late 70s and 80s all the way up to the 90s. So he studied it. Now, this is later as we were evolving, but he studied it, and this was a very important paper of his. What he did was he looked at adults that he was operating on and measured a bunch of stuff during the operation at various times, including jugular venous saturation blood. And he calculated an estimated cerebral metabolic rate for oxygen consumption, which the formula is there. And he calculated this physiologic variable, which I have a very loose understanding of, I will be quite honest. It's a little above me. But essentially, he came up with this chart that is very important. What it shows is that If you cool somebody's brain, let's say to 20 degrees, which is about close to 18, you reduce their cerebral metabolic rate by 76%. Okay, so you have 24% of baseline. And that gives you a rough duration of circ arrest time between 17 and 24 minutes. If you go cooler to 15, and that we'll get into the reasons why it can be detrimental, but essentially, if you go lower, you have a longer duration. So this proved what we were doing for the last 70s, 80s, and up to the 90s, that deep hypothermic circulatory arrest would work and give you a safe time to where you could shut the pump off and start sewing quickly. Now, we monitor the brain in a number of different ways. Temperature monitoring, and our brain monitoring is it's not crude, but there's very limited ways to do it. We have cerebral oximetry, but probably the best thing to do would be continuous EEG, because it measures activity, and therefore, if you get to EEG silence, you will have maximal suppression of cerebral metabolism. You know that the brain is cold and cerebral metabolic activity is low or nil. So when we're doing these operations, you could, instead of cool to a temperature, because everyone's different based on their BSA of how fast they're going to cool. If you have EEG, you can cool to EEG silence. And this is a paper out of Penn, which was very helpful, where they looked at temperatures of patients to where they got to EEG silence. And it sort of confirms some of Greep's data. As you cool to a temperature down to 20, well, some of the patients are at EEG silence. And certainly as you go lower and as you get to 15 degrees brain, more than half the patients are EEG silent. So it varies per patient. And I use intraoperative continuous EEG on arch surgery today, and I wait till it's 5 minutes of EEG silence, depending on what we're doing, and then go for it, especially if I don't have antegrade cerebral perfusion or retrograde, which we'll get into in a second. So this is a very important thing. So people have still used deep hypothermic circulatory arrest, even to this day. This is a study out of Yale by John Eleftheriades, who's a very prominent aortic surgeon who's done a lot of work. And he's actually the one that gives us the guidelines of 5.5 centimeters. This all came out of his work. He is still a zealot for DHCA, even in 2018, which I'll tell you is outdated, and I hope to show you. But this is a paper in 2007 where he looked at 400 patients, 22% were emergent. He cooled them to 19 degrees bladder temperature. So that means their brain is even colder, usually because it takes longer to cool the visceral organs. We measure bladder temperature and nasopharyngeal temperature, thinking nasopharyngeal temperature is really brain temperature. And so they were pretty cold in this. Average period of circulatory arrest, 31 minutes, excellent operative mortality, excellent stroke and seizure rate, very low. But he commented that when he went over 40 minutes, he saw a dramatic increase in his adverse neurologic injury, 13%. This data of 40 minutes was also found and observed by the large series. This is Stanley Crawford's data written up by Lars Svensson in 1993. This is like 600 or 700 patients, I believe. Same thing. When you hit 40 minutes, when you're just using deep hypothermic circulatory arrest alone, you start to have neurologic injury. So to summarize our first modality here, DHCA still is the simplest form of protection, and it remains the most commonly used strategy worldwide by people that don't do aortic surgery a lot. The community surgeon, everyone knows on their cardiac surgery boards that if you had a type A dissection and you could femorally cannulate the guy, cool him down to 18 degrees, circ arrest him, and get him through, that is a perfectly safe, acceptable answer. It is safe. I would argue it's not ideal, but it's safe. And in this database paper of over 12,000 arch cases, it's still the most common. There's a variety of different ones, but a quarter of surgeons still use DHC alone. So it may be outdated in the high volume aortic centers, but worldwide it is not. It offers you safe brain protection for 30 minutes. increased risk of adverse neurologic outcomes when you hit 40 minutes. And I still use occasionally DHC alone, especially on operations of the descending aorta when you can't provide antegrade cerebral perfusion. But we rarely use it for aortic operations through a sternotomy because you can give cerebral perfusion, so, which we'll get to. So advantages, again, you can really, going cold, you can suppress cerebral metabolism, and it gives you a truly bloodless operative field, clearly. But there are disadvantages. So as we touched on, prolonged circ arrest time, the neurologic injury goes up. It takes a long time to sit there. You put them on bypass, and literally you're sitting there doing nothing a lot of times, waiting to get cold. And prolonged bypass is bad for you, period, the end, no matter what. If you can have a shorter, speed in cardiac surgery does matter, and certainly shorter bypass runs matter. You can develop coagulopathy from going cold. It's been shown in the lab, neuronal apoptosis, renal dysfunction, really endothelial dysfunction in a number of your different organs. So it's, there's some cost to deep circ arrest. So around late 80s, early 90s, people started saying, well, can we do better? Can we improve on our neurologic outcomes? Can we provide blood flow to the brain? Cerebral perfusion during circulatory arrest, not as a replacement, but as an adjunct to DHCA. And there's two different modalities that were developed, retrograde and antegrade, which I'm going to show you. And really this is to say, can we do better, not really in the short circ arrest times, but in the extended circ arrest times when you're doing the whole arch, when it's really complex. And cerebral perfusion has really transformed modern aortic arch surgery to where we are today, where we can ensure really good outcomes, really good neurologic function, almost normal after an arch operation. So we're going to start with retrograde. So back to the pump and our schematic. Retrograde perfusion was first developed to treat a massive air embolism during bypass. So what you do is, in this model, you have an arterial cannula in the femoral artery, and your venous cannula, you have bicaval. Now, we do bicaval venous cannulation for a number of different operations. When we open the left atrium, the right atrium, you have to have it, otherwise you'll have air in your pump. So you put a cannula up the SVC, put a cannula in the IVC, and you snare this cannula in the SVC, and you basically infuse blood up this cannula. It goes retrograde up the venous circulation into the brain, and that is called retrograde cerebral perfusion. The first guy to do it for arch surgery was this Japanese surgeon, Dr. Ueda. Again, once you're ready to do, so you've cooled down to 18 degrees, you get ready, you turn the pump off, and there's different ways to configure your pump. You can have a bridge between the arterial and venous circuits, but essentially you are infusing cold, oxygenated blood up the venous system through the SVC at about 300 to 500 cc's per minute, and we measure pressures 20 to 25 millimeters of mercury. Let's see here. Okay. What are the advantages and disadvantages? Well, it is the best modality that we know of flushing embolic material from the cerebral circulation. All the embolic stuff, we feel that RCP is the best modality. And that will come back later in this talk. And it is very good at maintaining the brain to be cold. So I didn't mention this, but people who did deep hypothermic circulatory arrest, when you shut the pump off, you still want the brain to remain cold during that whole time while you're working, those 30 minutes. It's, when it stops being bathed in cold blood, obviously it gets warm. People actually, and still do, pack the head in ice. Okay, you've heard about that. So RCP maintains that cold. You got cold blood running through the brain. So it's excellent at these two things here, flushing embolic materia and keeping the brain cold. It does improve morbidity and mortality compared to DHCA. And again, it's adequate for shorter circ arrest times, 45 minutes. But it has been studied extensively by Dr. Greep and others, And when they've looked at blood flow in animals and in transcranial Doppler measurements in humans, it doesn't provide that much cerebral blood flow actually getting into the brain. It has never been shown to truly support cerebral metabolism. If you go up on this pressure, retrograde has been shown that the disadvantage is you can have brain edema, and there's a high incidence of this transient neurologic dysfunction when you compare it to antegrade cerebral perfusion. So let's compare our first two modalities. When you compared deep circulatory arrest alone to deep circ arrest with RCP, the RCP is superior in that it reduces mortality and stroke. These are from two large studies out of the major Houston groups, Caselli and this is Safi's group. Safi's group then in the mid-2000s did a univariate and multivariate analysis. This is over 1,600 patients combined, but in their study over 1,100, RCP was protective against mortality and stroke. The TND rate, this obtunded confusion, 25% in deep circ arrest cases, it was lowered to 15%. So RCP was a huge advantage. There are a lot of groups that swear by RCP to this day. It's a big controversy in our field. So now we're going to move on to antegrade cerebral perfusion. Now, antegrade cerebral perfusion actually preceded everything. Interestingly enough, by the giants in our field did it. DeBakey and Cooley operated on an arch aneurysm. This was the first reported one. And they basically, I don't know how cold they went, but they circ arrested a patient, opened the arch, and stuck catheters up the carotids. I don't know if they did the subclavian, but they'd cannulated the carotids and femoral artery, and they got this patient through. Now, they gave warm blood during this time. A French surgeon in 1991 brought this back, Jean Bichet, and he brought back antegrade cerebroplegia is what he called it, infusing blood at 4 degrees up the brain, again, keeping it cold during circulatory arrest. And he had pretty good results in 54 patients, 13% mortality, and a low stroke risk. And this was echoed at the same time, roughly, by a Japanese surgeon, Dr. Kazui, who was very influential, and we mimic some of his techniques still today in 23 patients. Low mortality, no stroke rate. So antegrade is literally giving it, as I can consider it, as God intended it. Blood antegrade up the arteries, okay? As if you were clamped with a cannula in the arch. Advantages, robust cerebral blood flow. So let me back up. When you do deep circulatory arrest and we open the arch, what you see is dark blood emanating backwards from the great vessels. It's impressive. Even though you've infused oxygenated bright red blood up, it comes back dark. And that, we think, is because the oxygen has been sucked out by the cells as it's coming back from the arch. I mean, there's no other way to explain it. ACP, you have, if we clamp the anomaly, I'll show you how we do this, but you see bright red blood. If you infuse it up the right carotid, you will see it come back down the arch through the left subclavian and the left common carotid artery. It is extremely robust blood flow, maintains cerebral metabolism. There's a number of animal studies, again by Dr. Greep and others, showing that it maintains, they measured pH, cerebral metabolites. They really took it down to the basic cellular level. It preserves metabolism and cell structure, this should say, compared to RCP. And it really changes the paradigm. So now you're not having circulatory arrest to the head. You've got blood flow the whole time to the head. So really, it's transformed the whole setup from a total body circulatory arrest to a lower body circulatory arrest because the brain's getting blood. And the spinal cord is getting blood through the vertebral arteries, okay? So really what is circ arrested when you use ACP is the abdominal viscera, okay? Which is why you need to stay cold, but maybe you don't need to stay as cold, which we'll get into. The disadvantages of ACP, you have to manipulate the great vessels, whether the method that we do it, which I'm going to show you, or what this picture, putting catheters up there. Usually in an atherosclerotic aneurysm, as everyone knows, the disease forms at branch points of the arterial tree. So these are fraught with plaque, and we hate sticking catheters up there. You can introduce air embolism, you can obviously embolize atherosclerotic plaque, et cetera, and it clutters the operative field. So we don't ever do this setup here, okay? What we do, which I'll get to in a minute, is unilateral. So when you look at the comparisons, again, I've touched on this. When you compare RCP to ACP, same temperature, animal experiments have shown that ACP is superior in delivering cerebral artery blood flow, so metabolism, structure, and reduction in cerebral edema, but RCP may be superior to preventing gaseous or particulate embolic injury. Clinical studies, there's two large retrospective studies. There's a reduction in TND with antegrade cerebral perfusion. This is from Greep's group. No difference in mortality of stroke, TND or dialysis, and this is with total arches, okay? So either ACP is slightly better or no different. There's been two small prospective trials. I should add ours on here, which we'll get to in a minute. Reduction in TND with ACP in 60 patients undergoing total arch. So look at this. This is a Japanese study. And with ACP, this is the transient neurologic dysfunction, the confusion. 13% rate with antegrade, 33% with retrograde. Lars Svensson looked at 120 total arches. He's a very fast surgeon, and again, speed matters. He saw no difference in anything. Mortality, stroke, he did neurocognitive deficits. He saw no difference with antegrade, retrograde. So somewhat controversial. This slide takes us through our evolution as we're about to warm up in temperatures. Again, in the 70s with Greep, it was cannulate the femoral artery. And as an aside, arterial cannulation has also been determined. The site where you cannulate is a factor in whether you get a stroke. We started out with femoral arteries and we've moved on. So in 2018, now we either cannulate the ascending aorta directly, we do some innominate cannulation, as do others here, or axillary artery. This is our primary go-to. And now instead of going cold to 18, we've added cerebral perfusion and really warmed up. So moderate hypothermic circulatory arrest with antegrade cerebral perfusion. Here's the initials. Again, the brain is perfused now. Antegrade cerebral perfusion when you do circ arrest with cold blood, but we thought, could we not have to sit there on bypass and wait to get cold? Can we do it warmer and still have similar or better results? Because remember, now that the brain is getting blood, we're only worried about the abdominal visceral organs. It may allow for shorter bypass times, reduce our cooling, rewarming periods, and avoid those adverse effects of long pump runs, coagulopathy, deep hypothermia, which I showed you, et cetera. Here's our method, and this is pioneered by my partner, Ed Chen. He certainly wasn't the first person to embrace axillary cannulation, but he, again, has been credited, certainly in this country, we've produced one of the major series, and we're always we're the moderate antegrade zealots, so to speak. So what we do is we make an incision in the right delta pectoral groove, and we dissect out the axillary artery, and we sew a graft onto it, an 8mm graft. Then we stick our arteria cannula into that graft. Then we go on bypass, and once we're ready to circ arrest, and now we're cooling to much warmer temperatures, all right? We put a clamp around the innominate artery and a clamp around the left common carotid artery. Okay, these are snares, but actually we use clamps. And we infuse blood at 10 cc's per kilo per minute, cold blood, 16 degrees, okay? So we treat both aneurysms and type A dissections in this matter, okay? And remember, as I said before, an ascending aneurysm is still getting a proximal hemiarch, okay? And this is what it looks like, so that we get all disease of the ascending aorta out, and this is what a hemiarch looks like. We basically cut out the underside or the lesser curve of the arch, leaving a peninsula almost of the great vessels, and then we sew our hemiarch onto that. So we've studied this in numerous different ways in papers here at Emory. I'm going to take you through a few of them. This was a study of 500 patients. We looked at both elective and emergent, and we had two groups. We actually had moved on. So this is moderate, so we weren't cooling to 18. We cooled to 24 in about half of them, and then 28, which is our standard for hemiarch now, in about 277. And essentially what it showed with this technique is equivalent outcomes. Mortality rates, these are elective cases, less than 5% in both. And these had a wide variety of other concomitant cardiac procedures going on. Stroke rates were actually better in the warmer group, okay? And the transient neurologic dysfunction, no difference, 3.8% in the mild, 5.5% in the moderate group. And renal failure, remember, that's the temperatures really impacting, we feel, the organ dysfunction in the belly, not the brain. No difference, very low risks of renal failure. The warmer group actually got extubated earlier. We couldn't really explain why. We don't have a reason for that. So in this paper, essentially we showed that doing these hemiarches with antegrade cerebral perfusion at bladder temperatures of 28 to 29 was safe. Then we said, can we take this to a total arch with longer circ-arrest times, okay? To where we have to replace everything and reimplant the great vessels. As you can see here, here's left subclavian, carotid, and innominate. This patient also had a root right here. So we looked at total arches. This is a dated paper now. We got it out in 14, but it was 145 totals, most of them elective, 23 emergent type A's. This is at least doubled now, if not more, and about 50 patients of these were redos. Outcomes, these are long operations I'm going to show you, but mortality rates, 9.7%. Could be better, but in the literature, that's about where everyone lands, especially with the redos in there. Stroke rates, low, 2.8%. TND, 5.6%, and low renal failure rates. When we did a multivariate analysis, well, I'll get to that in a second. These are our stats. What you can see here in our elective and emergent total arches, we were pretty warm, okay? 25 degrees in the electives, and actually in the emergent, probably because we didn't want to wait, 27 degrees. Circ-arrest times, 50 minutes, 53 minutes in elective, 60 minutes, almost an hour of circ-arrest in the emergents. You can see the pump times here are about 4 hours. These are long operations, 3 hours of clamp times. And we looked at two different things in our multivariate analysis. First, we asked the question, is the temperature to which you cool a risk factor for our major adverse outcomes? And really, this shows that it wasn't. We had a p-value of here of 0.05, but otherwise, temperature, when we ran everything, was not a risk factor for death, stroke, TND, dialysis, or prolonged ventilation. We then asked the question, is the time of circ-arrest a risk factor, either with this antegrade moderate? Also, did not show significance in our major adverse outcomes. So then we asked the question, can you do it in type A dissection? Type A dissection is a different beast. The patient's in a different physiologic manner coming in. They have malperfusion, et cetera. So this is a paper where we kind of stepped it back. We looked at our overall experience. When Ed started here in 2004, he was using antegrade, but he was still going cold. By the time I joined the faculty or got here in 2008, he was already at 28 degrees, and I've continued that mantra, and really so have all of our partners. So now when a patient needs a type A dissection, our go-to temperature is 28 degrees. Now, if they come in with renal failure, we adjust this in our mind. And we may go colder to try and keep the kidneys alive and better protected. But in general, 28 degrees. So in this setting, we compared deep plus antegrade. And let me explain. We use this, instead of ACP, we've added unilateral selective antegrade cerebral perfusion. Many people will do what I showed you in that picture, catheters of both head vessels or all three. But we have not done that, and we have shown no issues with just unilateral up from the right axillary artery. So unilateral selective antegrade cerebral perfusion. This is the deep versus moderate group. Mortality rates. Mortality rates for type A dissection worldwide, to step back from IRAD, is 25%. Really in expert hands here on this at Emory, we're close to 10%, okay? So the deep group, the mortality rate was 14% in this cohort. Again, this was included from 2004 on. This study definitely has a time bias in terms of when the operations were done. We got better later in the series, 9% mortality rate. Strokes, 8%. It's a little high, to be honest. It could be better. TND is 7% and 4.9%, no difference. Renal failure, no difference. acceptable, good results. We propensity score matched the two groups and asked the question, does temperature matter, again, on our 4 major adverse outcomes, and it did not. So deep versus moderate, it showed they were equivalent. Again, lower mortality, but not statistically significant in the moderate group. We proved it's an effective management for arch surgery. So to sum it up, moderate hypothermic circulatory arrest with unilateral selective antegrade cerebral perfusion based on all our work here. We've shown it's safe, provides excellent brain protection, visceral organ protection for a basic arch category. So elective case, hemi-arch, something that we think is only going to require less than 30 minutes, and a total more extended arch time. It's safe for both. So now we're going to get down to the nitty-gritty of where we are today. For a subtotal, what we would call, if sometimes we only replace to the left carotid, that's kind of rare. More often, we will go to the left subclavian. Every little inch here adds risk, bypass time, et cetera. As soon as you decide that you're not going to make a hemi-arch and you're going to have to reimplant 1 or 2, it's like another hour of bleeding and bypass. So in today's sort of worldwide consensus, using these 3 methods, if you're going to do a subtotal total arch and you're going to be circ arrested for more than 30 minutes, the consensus in most of our colleagues worldwide that are true aortic surgeons, everyone recommends antegrade cerebral perfusion as opposed to retrograde. You have to have some kind, okay, and it's still slightly debated, but I think most people would agree you need antegrade. There's no clear consensus about temperature, whether it's deep or moderate. Some people do deep, some people do moderate. The more controversial area lies in the straightforward ascending aneurysm where you're going to do a hemi-arch. I mean, some really fast surgeons can be circ arrested for 10 minutes, okay, and sew this. So when you're having a short circ arrest time, a lot of people will say, it doesn't matter what you do. You can go cold with no cerebral perfusion. You could do deep retro or moderate antegrade. Most people of our colleagues would argue, though, you should have some sort of cerebral perfusion, but no clear consensus between deep retro and moderate antegrade. But as I showed you in that paper before, worldwide, most surgeons still using deep alone with no complex pump setup to give retrograde or antegrade. So it's kind of interesting. So based on this sort of controversy that rages in our field, there's zealots that are deep retro. A lot of the world has gone to what we do, moderate antegrade. We wrote a grant to conduct a prospective randomized trial because it's never really been done. And as we get more attuned to neurologic injury and overall cardiac surgery, we realize that we as cardiac surgeons are biased and we don't really evaluate our patients' neurologic injuries too well. I mean, can you squeeze your hands, wiggle their toes? Thumbs up. That's not really sufficient. All right, so I wrote a small grant with some institutional funding as well to look at this topic, all right? So background is what I've shown you. These are the highest risk patients for neurologic injury because of circulatory arrest. And when you look at the studies for elective hemi-arches, the data is amazing, all right? It's too good, frankly. So reported incidence of stroke in elective hemi-arch is between 2 and 3% by a number of papers. Great groups. The 2 Houston groups, us. Here's Penn, and here's a large German group. It's too good. Even our own, too good. Now this paper was a game changer right here. This was a paper out of Penn, and what they did is they really looked at stroke after AVR, aortic valve replacement. This is as TAVR is coming to be the forefront, okay? And this was a very eye-opening paper. 200 patients, roughly, with a mean age of 76 years old, undergoing AVR. Now, a lot of them had concomitant surgery, CABG, double valve, et cetera. And this was really an intermediate risk group if you use the TAVR nomenclature, all right? Between STS risk scores between 3 and 7. I think they fell like 6, kind of an older group. But they said, all right, everybody gets a mandatory neurologist adjudicated exam, and everyone gets a post-op brain MRI. So When they looked at the strokes, these clinical strokes first, the surgeon commented that there was 7% in their series. Not surprising, the neurologist said, 17%. But this is the really fascinating area. 60% of patients, if you MRI them, after AVR will have silent infarcts. Now, no one knows what to make of that. This happened to me, actually, probably 3 weeks ago. A patient had a slight 1-minute weakness after AVR. Code stroke was called. The neurologist get in there. Head CT, non-con, negative. And the lady's now clinically normal. CT with contrast, normal. Okay, so there's going to be nothing major. And I said, do not do the MRI. It is not going to change anything, and I will guarantee you it's going to show a stroke. That's the numbers. And we were fortunately able to say this was a TIA based on STS recognition, but it can really hurt you if you look, but it's there. So again, based on limitations of the previous hemiarch reports, they're all retrospective, lack of neurologist adjudicated data, lack of mandatory MRI imaging, I would argue that the true incidence of neurologic injury after elective hemiarch, despite what I've told you, we don't know. So, as I've also mentioned, it's controversial what's the best method. It's really unknown, even though we're zealots about moderate antegrade here. So, we conducted the trial to two aims: to define the true incidence of neurologic injury following elective hemiarch. This is your straightforward ascending aortic aneurysm. And to determine whether the two most commonly used in high volume aortic centers, two most commonly used brain protection methods, moderate antegrade versus deep retro, are equivalent, all right? Our primary endpoint was a composite because we knew the clinical stroke rates were going to be low, as well as TIA, so we added a composite of stroke, TIA, and the MRI injury. Versus secondary endpoints alone of TND, we did neurocog tests and plasma S100 levels, which is a generic plasma biomarker of neurologic injury. Our design, we did this over about a year. Funding, $50,000 buys you 20 patients. That's it. 20 elective hemiarcher patients randomized to these two strategies. We excluded redos, emergence, total arches, aberrant subclavians. Myself and Ed Chen were only the two surgeons that did this. Again, here's our setup, moderate antegrade. These are consensus definitions. So now we're using nasopharyngeal temperature. You could cool them to 20 to 28. Again, clamps across the innominate carotid, and blood goes up the right carotid to give antegrade cerebral perfusion, versus retrograde, where you're giving the blood up the SVC. Here was our neurologic assessment study. So we used CNS vital signs as a computerized neurocog study. We had the patients do it preoperatively and then at post-op day 7 and 6 months out. Same thing with NIH stroke scale. We had the neurologist examine the patients as soon as they were extubated and prior to discharge. We did biomarkers, and we had enough money. The MRIs are really costly, so we would have loved to have had a preoperative brain MRI, but we had one right before discharge. Busy slide. I'll get through it really quickly. These were young, healthy patients, okay? 56 years old, most of them male, really minimal comorbidities here, okay? Well-matched apples to apples cohort. Their aneurysm size, not all of them were, the primary indication was their aorta. A lot of them had primary indication was bicuspid aortic stenosis, things like that with a concomitant aneurysm. Almost half the patients in each group had aortic root replacements, okay? So these weren't, we rarely just have to operate on the aorta. Frequently we have to do other stuff in there. All were circ-arrested, had hemiarches. About 2/3 in each group had AVRs. There was no difference. This surprised us. We thought the pump times in the moderate group would be statistically lower. Well, they were lower by about 26 minutes, but not statistically significant. Clamp time, again, because you don't have to cool and rewarm for a long period of time. Clamp times were the same. Circ-arrest times, same, 20 minutes in each group. You can see here they were preordained that this group was going to be cooled to 19 degrees nasopharyngeal, or less than 20, excuse me. So literally we sat there waiting till it said 19.9, and then we would circ-arrest versus 26 degrees, a big difference. And no difference this also surprised us. We thought it'd be statistically a lot lower. It was 32 minutes there, lower in the moderate antegrade group. Intraoperative data, we thought maybe there would be less blood transfusions with the moderate group. Nope. Very low rates in general, but no differences in blood transfusions, et cetera. No difference in post-op ventilator requirements, ICU or hospital lengths of stay, 2 to 3 days in the ICU, 8 days length of stay, no difference in bleeding, chest tube outputs. There were no deaths, no pneumonia, no renal failure, no dialysis. One patient had to go back for bleeding, and post-op AFib, no difference. So equivalent, this is kind of what we thought. But here's the key slide. So again, we had 1 stroke in each patient. Those deficits, by the time I saw them back at 1 month, were largely gone. There was a higher rate of TND in the warmer group, not statistically significant. The biomarkers of brain injury, there was no difference between the groups. They peaked, not surprisingly, on day 1 and came down. But here's the key finding of this pilot study. When you MRI'd these patients, 45% of the deep retro group had DWI lesions. These are silent infarcts. Every single patient in the moderate antegrade group had it. Furthermore, when you looked at the number of lesions, they were significantly less in the deep retro group compared to the number in the moderate group. Now remember, I told you that deep retro has been thought to be superior to antegrade in terms of de-airing or preventing gaseous particulate emboli, okay? Neurocognitive tests, it measured a number of different things. This is a computerized test. I'd say this is a limitation of this study, and hopefully if we get to a next phase, we will do it different. But it gives you a total score. Essentially what it showed, no significant groups in neurocognitive tests. We thought we would see some based on those clinically silent infarcts. No difference between the groups at baseline, right after surgery, or at 6 months. Yes, it decreased and then came back up. But nothing there, no signal there. Here's what one of these silent infarcts looks like, okay? A big spot right there. Again, so the primary endpoint was met in 45% of the deep retro group, but in every single patient in the moderate antegrade group. This was significant. None of the secondary endpoints on their own were equivalent. So clearly this shows the true incidence of neurologic injury following elective hemiarch replacement is higher than previously reported. Clinically evident neurologic injury equivalent between the two methods, but this subclinical neurologic injury significantly increased with the moderate antegrade. So if I were having this operation, despite our really, our proclivity on doing moderate antegrade here, if I had to have this operation on myself and somebody said, well, you're going to do, clinically you'll be the same, but you're going to have more hits to the brain, I would want deep retro. I don't know what it means, but it's brain injury. So we're trying to take this to the next level, obtain NIH funding. We're going to add another institution and do a prospective randomized trial. The only other direction I will mention going on right now in cerebral protection and arch surgery is an ongoing NIH-funded trial at Duke. We're one of the enrolling sites. It's looking at it's a different design, and I don't 100% know it all, but it's basically looking strictly at temperature. It's not varying the different methods of cerebral protection during arch surgery. So I'll stop there and answer any questions. Thank you.
Thanks, Brad. That's really interesting. So what about sort of pharmacologic adjuncts, and have people thought about that? I'm sure they have along the way, and my guess is not much help there to protect the brain.
We give steroids before surgery and at the time of induction, and that's the main. Everyone does that. But other than that, it's sort of all over the map. Nothing has really been shown. There's been a little bit of stuff in spinal cord that's different for descending operations, but in the brain, nothing on the pharmacologic that is truly impactful.
Question?
Brad, that's really very good work, and it's thanks for sharing that with us. So I guess one question for you is, you look at that in your study, in your pilot study, you look at the 100% rate of imaging infarcts on MRI, and you ask yourself, gosh, it would have been great to have the pre-imaging, because these patients might have had, aortic valve surgery, AFib. They may have, I don't know if we crossed their valve during the cath procedures, because we know they're also associated with neurologic injury, even manipulating the aortic valve. And anyway, so I applaud the great work. I just ask you, with the numbers being relatively small, that 100% injury, you really have to ask the question, is that even though you match them, they were randomized, is it possible that those patients had higher rates of disease ahead of time or injury? And because otherwise, do you think this whole de-airing is enough to explain the difference? It seems like everything you told us up to then, we're all like, all right, let's go for this antegrade moderate, and then you hit us with this thing. So just some comments on that.
You hit it right on the head, Abib. I mean, we were like shocked to see that retrograde was superior in this method. Your comments are correct about the MRI, and there's no doubt we'd love to have seen, and that will be in the next step, the preoperative. I'm almost positive, because Jason Allen is our neuroradiologist guru who read every single exam on this campus. And I think with the DWI, he could actually tell just then that these were new acute infarcts. They were truly there after the operation. So that almost answers the question. I think still he would have rather loved to have apples to apples, a pre and a post. But yeah, now I will tell you that when you do retrograde, and when you're de-airing the arch right before you reinstitute full bypass, and I point this out to the fellows because it was pointed out to me when I was learning it, you can see little things in the blood, grossly, coming up through that dark blood, gas bubbles, et cetera, in the blood to your eye that, antegrade, it's going much more briskly. So it may be there, but you just can't see it. But you can definitely see that to the naked eye. So unfortunately, I think that retrograde is a better de-airing thing based on this study, I think. Again, small numbers, and we'll see if it pans out. But it very well may be. And so for the short circuit rest time, it may be better. I mean, it may be better. Because I guess what you'd say is that temperature is going to take care of your metabolism for a short circuit rest time. So then the importance of embolic phenomena supersedes your metabolic injury. That's how I've explained it, certainly when we've written this up as our discussion. Perhaps that's my hypothesis to explain the results, but I can't wait, hopefully, to conduct this on a larger scale.
Brad, how about, has anybody tried some type of filtering phenomenon in this situation, or is that just you couldn't do it?
Like the TAVR cerebral embolic?
Yeah, that you've got particulate matter that's leading to these embolic events that you think, and could you temporarily put in, as you start this thing, with the backflow of blood, put a filter there that would cut out some of that?
No one's looked at it. I know that I know of. And it may be sort of clutter the operative field, would be my one comment just off the top of my head, but no one's looked at it.
Can you talk to us about, is reperfusion injury an issue with the retrograde? I mean, you are providing retrograde flow, and as you mentioned, there's perhaps a little more cerebral edema. Certainly in the cardiac space, there's all this, literature about reperfusion injury. Any thoughts about that?
The basic science work done has taught us to when we go back on bypass, we stay cold with the reperfuse it for 5 minutes, and then we start rewarming. But differences between retrograde and antegrade has never been shown. It's a good thought. Theoretically, in both methods, the brain should remain cold. So it may not be as big of a deal.
Brad, that was great. The lungs do a perfect job of filtering out micro bubbles when we do bubble studies on echo. I was just thinking about, they work as he mentioned filter, they work as a great filter, but there's some way you ought to be able to filter that out. But
Yeah,
however the lungs do it is the way to do it.
good point. And there's filters in the pumps and things like that, but and I don't know if it's air. I don't know what it is. I really don't. We're flooding the field with CO2 to displace air, et cetera. But it's there. It's microscopic, but it's there.
Okay. Well, Brad, thanks a lot for a really interesting talk. Really appreciate it.
The preceding program is copyrighted by Emory University.